morning. Today's class will be on the management of non-carious lesions. Non-carious loss of tooth structure is a common problem which occurs in life. Problems arise when the rate of loss becomes too excessive, which causes functional or listening problems or sensitivity to the vision. Eckler suggested the term tooth substance loss to encompass conditions such as attrition, abrasion, and erosion. Later on, Smith and Knight suggested the use of the term tooth wear to refer to these conditions. Tooth wear is defined as a surface loss of dental conditions other than that caused by caries or trauma, which is a cumulative lifetime process which is irreversible. Tooth wear is a common condition which affects probably 97% of the population, with only around 7% showing pathological degrees of wear which require a restorative procedure. Enamel is one of the few tissues in the body which is not able to repair or replace itself, unlike skin, blood cells, or fractured bones. Fortunately, dentine shows some reparative mechanisms in the form of deposition of inflammatory or operative dentine in the bite chamber as a reaction to tooth wear. Attrition is defined as the mechanical wear of the incisal or occlusal surface as a result of functional or parafunctional movements of the mandible, and this definition is according to Stirling. It also includes the proximal surface wear at the contact area because it is visual to the human. It is an age-dependent continuous process and it is usually physiological. Attrition is caused by the contact between surfaces and is usually hastened by a coarse diet. Attrition is also caused by parafunctional habits such as bruxism. Advanced cases of attrition show pulpal pathology, impaired function, occlusal disharmony, and aesthetic disfigurement. Vertical loss of enamel of up to 50 to 60 micrometer per year is considered physiological. Attrition can predispose to or precipitate any of the following conditions. Proximal surface attrition or proximal surface spacing results from surface tooth structure loss and flattening and widening of the proximal contact areas. There is an increase in the dimension of the surface area proximally and a decrease in the mesodistal dimension. The overall arch length is decreased in the case of proximal surface attrition. In occluding surface attrition, there is loss and flattening of the occluding elements, which leads to loss of vertical dimensions of the tooth. There is deficient masticatory capabilities and cheek biting. In advanced cases, reverse crust may be present, which will replace the occlusal contact and the inclined planes. Cases of attrition show shiny wear facets with well-defined borders. These facets appear flat and flush with the opposing tooth. The enamel and dentine wear the same rate, and there is possibility of fracture of the crust or the resolution. Equal wear is seen in both the arches, and there is presence of peripheral ragged sharp enamel edges. The presence of a hypertrophic visitor is a sign of the impact of bruxism. TMJ problems can be elicited by the overclosure situation in which there will be an overstretch of the joint ligaments. Severe occluding surface attrition may occur predominantly due to the horizontal masticatory movement of the mandible, which causes an extreme strain on the muscles of the stomatothoracic system. This is a case of extensive loss of coronal tooth height in a patient with anterior S2 exclusion caused by attrition. Restorations may be required only in the following conditions. Such situations which require restorative mandible may be areas of attrition which is variously involved when the defect is sufficiently deep to compromise the structural integrity of the tooth, when there is intolerable sensitivity and the tooth is unresponsive to conservative desensitizing measures, when the defect contributes to periodontal problem, when the area is to be involved in the design of cavity, when the depth of the defect is judged most difficult, or if the patient desires aesthetic improvements. Metallic or metal-based restorations are preferred for the restoration of areas subjected to attrition because these areas are high stress concentration areas. Various treatment modalities are recommended for lesion. In pulpily involved teeth, endodontic therapy or extraction is suggested depending upon their restorativity. When parafunctional habits are present, such as bruxism, the functional habit should be controlled with the use of protecting occlusal. In case of myofunctional and TMJ symptoms in the stomachomatic system, they should be diagnosed and resolved by modifying the occlusal split. Occlusal equilibration is done by selective grinding of the tooth surfaces that includes rounding and smoothing of the vertices and creating adequate overlap between the working teeth lines to prevent further cheek grinding. During the last three procedures, the exposed sensitive dentinate areas are protected by using a fluoride solution, and the carious lesions are restored, and the periodontium should be checked for any pathologies. There are two schools of thought for restoring the vertical dimension. The first school of thought is the addition of increments gradually, in which the increments are progressively added to the harsh bone at the rate of 1 millimeter per week until the patient reaches the desired vertical dimension for restorative procedures. However, this procedure is time consuming. The second school of thought, the patient is taken to the desired vertical dimension immediately. This approach is less time consuming and considerably less adjustments are made. For any of the procedures, it is necessary to wear the appliance for at least 6 to 8 weeks, and the splint can be removed once the muscles of mastication are flaccid and when there is no tenderness to palpation. When the TMJs are free from pain, palpation, and reflex, then it is safe to proceed to the restorative care. Anterior pipe pain is used as a reduction of bite. It occurs by altering the rate of eruption of posterior teeth relative to the eruption of lower incisors that are in contact with the white vein. They are especially useful in actively growing patients and show the highest rate of eruption in the first 2 months of feeding the appliance. In certain cases, intentional endodontic therapy has to be performed in hypereruptive teeth or triple teeth and mono teeth that have to be reduced drastically and when the pulp is certain to be involved. In such cases, angled radiograph should be taken prior to and during the treatment, and the aid of magnification and illumination can help to safely locate the canals. The other non-carious lesions such as erosion, abstraction, and abrasion will be dealt with in the next class. Thank you.